Un momento cinese.
Yes, yes, thank you, Luca.
Ciao a tutti.
Magari parliamo in italiano, but now
No.
I have to continue in English. So I'm very happy to introduce the next two speakers for our last presentation today, which hopefully can be a nice wrap-up. So the title is Redefining the Athlete, Infusing Research to Clinical Practice. And I cannot imagine some better speakers than Karen Litzy and Sarah Haag from the States. Unfortunately, not here in Switzerland, maybe in the next years, but they are connected online. So Karen is from New York and Sarah from Chicago. I'm correct? Maybe, hopefully, yes. So Karen they don't need any presentations. Karen is very well known. By the way, it's a very dynamic duo already at the World Conference of Sports Physical Therapy back in Vancouver a few years ago. And Karen has a very famous podcast. Wait a moment. Wealthy, healthy, smart. So healthy, wealthy, smart. Yeah. And Sarah is very, very into pelvic issues and women's health and so forth. So I will not continue, and just happy to follow your presentation. Welcome.
Thank you so much. We're very excited to be here, but I think we'd both really rather be in Switzerland with all of you. So I'm just going to share my slides. So Karen and I are going to be talking a little bit about redefining the athlete, infusing that research into clinical practice. And when we say that, I think both Karen and I do work with athletes, but certainly not athletes at the level of some people working with elite athletes, professional athletes. So we wanted to talk a little bit about all athletes, and perhaps those athletes that are being seen in a larger volume in clinics around the world. So defining who our athletes are. So the elite athletes are up there at the top of the pyramid. There's not as many of them as the other types of athletes. And these are athletes who are working out, training, exercising for more than 10 hours a week. And then we go down a little bit to the competitive athlete, training maybe 6 hours a week. And now we're looking more at those collegiate athletes, high school athletes, still again aiming to improve performance. Then we have recreational athletes, training a bit less. It says greater than 4 hours a week, but when I was doing more recreational athletics, it was not quite 4 hours a week. And then we have our other people that we'll see in the clinic. We have our exercisers who are physically active 2.5 hours or more per week. And then unfortunately, especially in America, our largest population are actually going to be people who are physically inactive, and they wouldn't consider themselves athletes at all. And one of the reasons I bring this up is that really it's all the athletes in the top 3/5 of that pyramid who have an intention to compete. So that's kind of their goal, their aim, what they're hoping a physio can help them get back to. But then we have to acknowledge that in the clinic, we're going to see, again, a lot more exercisers. So what should we do? You get a new person in the clinic, depending on your patient population and your experience. We're going to be hopefully wanting to apply an evidence-based approach to their plan of care. And a lot of clinicians don't have access to research, to have access to all of the articles, the wonderful research that many people who have spoken here already produce. So what do? A lot of them will have a Google. Now let's just say that female who's calling herself an athlete is in your clinic. What are you going to find? Well, you're going to find about 25% less articles, whether you go just straight up Google Scholar or if you get into PubMed. There are just more articles and more research on men than on women. And looking at research overall, less than 40% of participants in studies were female. So again, so the research that's being produced, it's kind of reminiscent of a lot of the cardiac and heart research that was done. It was done on males And then it took us a long time to figure out, oh, that doesn't really apply to females. Females are different. And this is an example of what you might find. We love systematic reviews. It's looking at a big pile of evidence and kind of distilling it down to seeing, so really, what is the best answer to this question right now? And I think this is a great systematic review, looking at elite athletes returning to pre-injury sport after ACL reconstruction. And that's great. And so if I went to that as a clinician and read about it, I would find that there were 24 articles that met the criteria to be included, which is great, except that only 2 of them were on female subjects for sure. There were 9 articles that didn't really describe the sex of the population included in that study. And then 13, so more than half, were definitely on male subjects alone. So we're going to end up with a conclusion, but the question is always, so then how applicable is that really to that person in front of me? And so when we look at that, it's kind of like any systematic review. You have to have studies to be included in, say, a systematic review or a meta-analysis, but there just aren't the studies there in that volume for women. Luckily, that's changing. I mean, I just loved listening to the previous presentation to hear of just the wonderful things being done and the considerations of how females are different than males being taken into consideration. But as of now, it's interesting to look at how just most of the research used for exercise testing and prescription has been completed on men. And so it hasn't been taken back through to have that all be looked at in a female population. And one of the most common reasons I saw when I was looking through the literature is that it's hard to account for the hormonal variations in females. And again, this was spoken a little bit about earlier, where, right, so their females change throughout their cycle. And while that does add a layer of complexity to a study, it's an important layer that would really make the research apply to females and help us as clinicians be better informed. But then we get into, so other than it maybe being a little bit more challenging than doing a study on a male where the hormones are less fluctuating, the way it is in sports in the world right now, male athletes are paid more compared to female athletes. So I do not want to say that males are more valuable than females, but they are certainly paid more. So when you look at where money may be invested, that's a huge limiting factor, I think, to having more excellent research done on females. And again, that final point, just to like the financial investment in male athletics in general is significantly more than investment in female athletics. So even looking a little bit into Title IX here in the States, where there needs to be equal opportunities for males and females to compete. So there's been several news stories on how the weight room for, say, the football team is noticeably better than the weight room or the training facilities for, say, the volleyball team, or the same thing for soccer or football. The female facilities tend to be less expensive than the males. So all of that's to say, so as a clinician, and I'm primarily a clinician, I get a patient in my clinic. Okay, so what do? I strive so hard to be an evidence-based clinician. So I look at my patient, and I have a 20-year-old female who identifies as a recreational athlete, and she plays football. And by football, I mean soccer for Americans. So here she is. There's literature out there, but she's not elite. She's not professional. And so I look at the evidence, and again, a lot of it is on males. So what do? So really, the rest of this presentation is going to be talking about how do you take the evidence that's available and that person in front of you, and then make the best clinical decision and come up with the best, most effective plan of care for that person.
Okay, great. Thanks, Sarah. So as Sarah said, with her great slide on that pyramid with the elite athletes on the top, and then as we go down, we've got your high school, college age, recreational, your exercisers, and the inactive folks. So what I wanted to do was get some numbers on this. So I looked up, this is through the National Safety Council, which is here in the United States. And as you can see, I selected the year 2019 because, as we all know, 2020 was a bit of a bust, certainly when it came to any organized sport and recreational activities. So as you can see on this slide, I know it's a bit of a busy slide, but as you can see, in the year 2019, we're looking at sports and recreational injuries that resulted in emergency room department visits. So as physiotherapists, we can probably say some of those people may need to come to us at some point for their injury. So the total was about 3.7 million. Recreational equipment, sorry. So when we look at our male versus female injuries, you can see that the male injuries were about twice as many as female injuries, 4.6 million versus 2.4 million. But what I really want you to look at is look at kind of the ages, injuries by age. So we've got that age 5 to 14. And again, going back to that pyramid that Sarah made, you know, we can maybe infer that some of these age 15 to 14 and certainly 15 to 24 might be in that collegiate or high school competitive age range, competitive area. So the sort of the upper part of that pyramid. But what I really want you to look at is this age 25 to 64, over 1 million injuries for sport and recreation, from sport and recreational injuries. And then when we look over here, they sort of break down where those injuries came from. You could see number one by far is this is exercise and exercise equipment. So when we think about that pyramid again, those exercisers on the bottom, maybe recreational athletes, just that step up, those are the people that the majority of physical therapists or physiotherapists are going to be seeing in the clinic. Like Sarah, I'm a primary clinician. And so these are the people that I'm seeing in my clinic, and that I think the majority of physiotherapists are going to be seeing as well. Not every one of us are seeing the elite athletes in our clinic on a regular basis. So we can go to the next slide. So what do we do when we have these patients come in and we're trying to treat them? So before we get to this slide, I'm just going to back up. I know a lot of you may be familiar with the evidence-based medicine concept of the three-legged stool. So within that three-legged stool, which was developed by David Sackett back in 1996, I believe, you've got three legs of the stool. You have your evidence, external evidence, your clinical expertise, and your patient values or circumstances to help guide the clinician and help guide the treatment. Unfortunately, what a lot of clinicians took away from the three-legged stool is that each leg of that stool are even for every patient. And we know that that is just not the case. So enter this lovely graphic here and paper by our friend here in the United States, Dr. Eric Mira. And this is the evidence-based funnel. So instead of using that three-legged stool, I really like, and Sarah as well, we really love this evidence-based funnel. So at the top of the funnel, you have all of the best available evidence, or the totality of evidence about the person with the diagnosis in front of you. Then as you go down into the funnel, you've got your clinical expertise. So as a physio, we take our clinical expertise to evaluate the evidence and then synthesize it for our patient, where we can create some hypotheses on how we want their treatment to go. And then the final step in the funnel is to present our findings and possible treatment options to our patient in a language they will understand. Because in the end, our patients are the ultimate decision makers. So if we are in fact practicing patient-centered care and evidence-based medicine, I think this funnel is a lot more practical for our thinking than the three-legged stool. So looking at the evidence-based practice as a funnel versus a stool, I think allows for more critical thinking on behalf of the clinician and a greater collaboration with the patient. And if we can do this correctly, I think we may have, and we'll get to this in a second, better adherence to the rehab program. Next slide. So when we think about what is the key to treatment, so we've Sarah talked about the different people we might be seeing. We're looking at the evidence through this funnel. So for me, the key to treatment, next slide, is communication, right? So this is where we as physiotherapists come in. And like Dr. Silvers Granelli said, wow, don't we have such a great opportunity to work with patients, because we can be with them a lot more than their physicians can. You know, we might be seeing them anywhere from 1 to 5 times a week. So the key to treatment is really good communication. So you can use that evidence-based funnel for your communication so that the patient understands what's going on with them and what their plan of care looks like. And communication is also key in adherence to the program. Next slide. So when we were doing this, Sarah and I were thinking, gosh, it's so great to have all of this evidence, well, or lack thereof, and to synthesize it for our patients to get a plan of care. But as we all know, and I'm sure people have heard this, the best exercise program for your patient as they go through rehab are the exercises they're going to do. Like Dr. Silver said again before, the adoption and adherence to even the injury prevention programs is challenging. So I found this in the International Journal of Sport and Exercise Psychology, Levy et al. In 2009, and they looked at investigating recreational participants, because I didn't want to use your elite athletes because their motivation and adherence is way different than your recreational participant who maybe has to work, who has children, who has partners, who has a lot of other obligations they need to meet. So this was a qualitative study. They only have 6 participants, which I realize is not a very strong amount of people, and we'll get into that, to see what their experience of adhering to their sports injury program is. And then the data collected from these interviews were broken down into a couple of different themes for analysis. Next slide. So what did they find? So they found, and Sarah, you could just kind of click through them really quick. I should have had this all on one slide. So what did they find? They found motivation or lack thereof, confidence or lack thereof, social support, and that cuts both ways, ineffective coping skills, and of course, pain. So let's break these down really quickly. So motivation, what they did find was even for your recreational athletes or your exercisers, not being able to participate in the physical and social aspects of their exercise or sport was a huge motivator. So this really motivated them to get back to doing the things that they want to do. But they found that they were really motivated in clinic with the therapist, but that motivation without the PT support outside of the clinic, so doing their exercises at home, kind of fell away. And we all know that if you see your PT 1 or 2 times a week and don't do anything else, it's going to make it a little bit harder and a little bit longer for you to get back to doing your sport. When they're talking about confidence. So again, through this qualitative study, they found that people felt like they didn't fully understand how to perform the exercise without the PT there. And they didn't really know what to do outside of the clinic. So again, this is a communication issue. I don't blame the patient for this. We have to blame either the therapist or the relationship between the therapist and patient. So better communication can help with both motivation and confidence. And they found that these 2 aspects were really indicative of not doing their exercises at home. The social support, interesting, like I said, it sort of can cut both ways. In some instances, it can help. In other ways, it can hinder. So early on in the rehab process, more support was better. Whereas later in the rehab, the patients felt like they were being smothered. And that was smothered by the therapist and also by their own support system. So for example, the task support was deemed effective when provided by the physiotherapist, whereas material, emotional, and practical support was better coming from friends and family. And then coping skills. So again, this is education and communication. So to improve these positive coping skills, we as clinicians need to educate our patients on the injury, on what the literature tells us and on our experience treating their diagnosis, to allow the patient to explore different behavioral, emotional, cognitive strategies. So I think providing good guidance and frequent feedback on how well the patient is doing was one of the things that all of the patients felt was really helpful for their coping skills. And finally, the last sort of thing that can make adherence difficult is pain. So patients think if they have any amount of pain, they're making it worse. I mean, if we were in person, I'd say, like, raise your hand if how many times you've heard that as a clinician. So what we need to do, again, as physiotherapists, is use our communication skills, use the evidence that says, hey, listen, if you're on this pain scale of 0 to 10 and you're around a 4 or less, it's okay. You're probably not going to make things worse. So we need to be able to communicate with our patients that a little bit of pain is okay, and help them find that threshold of where maybe more pain doesn't mean stop doing everything, but maybe it means to pull back a little bit and maybe change the program, but not stop doing anything altogether. So again, it comes down to good communication, good education. So when you think of that funnel that Eric Mira created, it all sort of fits within that funnel. And we'll go to the next. And what I want to say, one more thing on this study, is that the authors, of course, do find that recognition of adherence is very complex for a variety of different treatment regimens. So it doesn't necessarily follow that the findings that they found here can be applied to everyone across the board. And that certainly more future studies are needed around adherence to these, to our programs, especially in this recreational athlete population. Next slide. So what is the role of the physiotherapist? So again, if you're not familiar with the diagnosis, treatment, or outcomes, start with the evidence. Do your research. This is part of what we need to do as a physiotherapist. We're not there to just glide along and not delve into the research. And then if you're familiar with the evidence, again, we're going down to that second layer of the funnel. Reflect on the evidence as it relates to the person in front of you. After you reflect, hey, maybe you have to go and look at more literature, maybe needed, or hey, maybe there is not a lot of literature. Like Sarah said, for a lot of women, there isn't a lot of literature on what we can do with some of these recreational athletes. So what do? Through interview and objective evaluation, we find out what the patient needs from you as the therapist and for them as the patient. And I'm going to kick it over to Sarah to kind of finish it off with this concept of adaptability.
Okay, so adaptability, and this is kind of looking at us as clinicians, but also at the patients and at the journey that they're on. So I'll speak primarily to the role of the physio. So really what our job is to use the best evidence to create a patient-centered plan of care to help that person get back and meet their goals. And a lot of times we're going to have an absolutely brilliant plan that the patient doesn't like or doesn't want to do or isn't for whatever reason able to adhere to. We heard that even though we have plans or programs that work really well to prevent injury, still adhering to them is a problem. So I feel like recreational athletes, without the necessarily added stress of coach and team and everything else that goes along with it, is that hopefully we can help that patient adapt and find a path that works for them. And again, as clinicians, we do our best to stay up to date, to be the best physio possible. And yet again, that brilliant plan isn't working, even when the patient's adhering 100%. So what do? And it's all about kind of looking at the bigger picture and being willing to go, even though we're doing everything right, it's not working. What else are our options out there in the world that could still be supported by evidence and make good clinical sense with our critical thinking? So it's our role to kind of help find that picture or the best plan for that person in front of us kind of regardless, in spite of the lack of evidence that may apply directly to them. And so those are just kind of our thoughts on how to take a world full of evidence that might not necessarily apply to our population and what we can actually do in the clinic for those people looking for help. So with that, I surprised Karen with this slide. I made it up all myself. Thank you very much for inviting us. We were very honored by the invitation, and now we'll take any questions.
Many thanks, Sarah and Karen, for I think it was an excellent presentation. By the way, we are only expecting this at our conference. No, it was very good. So actually, we are a little bit running out of time because we have the upcoming delegates meeting, members meeting with our society, and so if you don't matter, I will I will say ciao to you now here. But remember that all of our followers and audience that if things are getting better, then they can for sure meet you at some conferences like the excellent Copenhagen legendary conference, and then maybe the World Conference in Sports PT, and maybe somewhere else. So we thank you again for your contribution. Like the other presentation, we will be able to show some of the content. So for sure it will generate possibly some discussion. But really, I think it was a wonderful way to wrap up this online symposium on women and sports. So thanks again, and I hope to see you soon. Huh?
Thank you.
Ciao.
Ciao.
All the best to the US.